Good afternoon and welcome to another edition of our webinar series from GRID. We have a lineup of fantastic professionals here with us today, and we'll be speaking, in continuation of our focus around accelerating the attainment of universal healthcare coverage in Africa. The focus of this particular webinar will be around us looking around building a sustainability framework or a sustainable healthcare financing framework for Africa. And for us, one of the biggest things we've seen, and just before this call, we're having a light conversation around the experiences from different countries. On this panel, we do have, like I said, a wonderful mix of individuals and professionals that will be bringing their expertise into this discourse. And I would like to introduce them one after the other. On this call, we do have Dr. Onya. Dr. Onya is the founder and CEO of Pelon Memorial Health Facilities. She has a track record, and she has multiple years of experience around healthcare service delivery. Shay, please you can put on the slides for the our participants to be able to see each of our panelists and their profiles. Okay, fantastic. So we have Dr. Onya. Dr. Onya is a medical professional par excellence, and has over 28 years experience working in the healthcare space. I do know something around Dr. Onya that she may not know. I've come across. I came across a society for quality in healthcare, and I found out that she was one of the individuals that brought that society together. And she is one of the main, if you say, many advocates for healthcare delivery in Nigeria. She also runs an accredited multi-specialist hospital in the heart of Lagos, and she's run that facility extensively for many years. On the panel as well, we have Dr. Leke Oshuniyi.
Good afternoon, everyone.
Good afternoon. Dr. Leke Oshuniyi is the MD at ICO Multi-Shield Limited. I think the first time I came across ICO Multi-Shield Limited was when I was a youth corper. And it's quite interesting that that has stuck with me. And many times I've heard people ask me, am I related to Dr. Leke Oshuniyi? And I said, probably by proxy, I'm his younger brother from another mother. Dr. Leke Oshuniyi is the director of the Royal Cross Medical Center, Ikoyi. Dr. Leke Oshuniyi also sits on, there are so many aspects of him I've seen. He sits on as the chairman of the Health and Medical Care Association of Nigeria, being one of the frontline organizations, the largest organizations for HMOs in Nigeria. So we see the value of the conversation here. And he's also an honorary fellow of the Institute of Health Insurance and Managed Care in Nigeria. He is also the Secretary General of the Association of General and Private Medical Practitioners of Nigeria, with extensive years of experience in both practice and healthcare administration as well. On the call as well, we have from Kenya, Nelly Ale. Nelly presently works as the head of health ecosystem at the MasterCard Foundation. She's an award-winning executive leader with performance track record. Nelly is someone that I've worked with closely for in multiple ways, looking at her track record of what she does. Interestingly, particularly within the not-for-profit sector, especially. She's held several positions around service delivery, technical advisory capacity, where she's significantly created impact within the healthcare space as well. We also have on the panel with us Dr. Okulaja, Olamide Okulaja. So Dr. The first time I came across Dr. I met Dr. Olamide Okulaja actually, was while we were pitching for a project where he was still working at the AUHC, and we've kept contact since then. And one of the biggest things I like about him is his tenacity and his interest into very practical and forward-thinking ideas when it comes to healthcare. Dr. Olamide Okulaja presently works as a technical assistant and health economist, working closely with the Honorable Commissioner of Health in Lagos. Some of the interesting projects you see in the Lagos state government I've had is footprint and fingerprint, even from the previous administration that I know. It may not say so much about that, but he is a healthcare professional by excellence, and we want to be able to bring his expertise around health economics into this conversation for healthcare financing. As well, on the call, we do have Mr. Adebowale. Well, let me address him in the healthcare pharmacist, Adebowale. He presently is the group head for government engagements and government fulfillment at Sterling Bank. I've worked with him severally on quite a number of projects, and I still am interested in working with him on other projects, particularly around private sector financing within the healthcare space. And we want to be able to bring that quality interaction. He does have a background in healthcare, but he's had an illustrious career working around healthcare financing and financing, specifically from the private sector side of things. We also have on the call, and very, very important, and one of the things we're trying to do on this call was to bring a multi-party conversation, to a multi-party viewpoint into this conversation. And by no means is he the least person on this call, but we wanted to be able to see also a government angle in this conversation as well. So we have on the call Dr. Abiodun Oyinneyin. Dr. Abiodun Oyinneyin is the DG for the Ondo State Contributory Health Commission, and he has worn many hats in the past, being also within the health management organization space. He's also worked a lot around developing and consulting as a technical advisor for emergency response. He's consulted, around World Bank projects and collaborated with health economics on funded projects with the Lagos State University College of Medicine. He's a fellow of the Health Insurance Advanced Studies, and he was, previously the managing director of a national health, like I earlier said, management organization. Dr. Oyinneyin, it's good to have you here as well.
Good afternoon, everyone.
Like I said before we start, as we were starting, I said probably at the end of this particular meeting, I will be able to ask to be indoctrinated as an honorary doctor. in this conversation, or as an honorary medical practitioner, because we have everybody on this call as a medical practitioner. So to just kickstart our conversation, one of the things that we had looked at was around the conversations with respect to healthcare financing in Africa. One of the biggest things that we see today from our last episode, one of the biggest issues that was basically brought up was the conversation around how do we mobilize appropriate financing into healthcare for Africa. Now, we've tried a couple of mixes, and one of it is, of course, the HMO approach. One of it is the taxation approach. But I wanted to kind of start with the process of saying, and I will start with Dr. Okulaja. How would you, fairly describe how, and you can use the Nigerian experience as an example, how would you describe the state of healthcare financing within the African or the Nigerian situation?
Thank you very much. I didn't think I was going to be the first person that would have a go at this, so I wasn't really prepared for that. But how would I look at it? There are different issues that currently occur in Africa, and there are different areas that we need to really look at when we describe health financing. Health financing has three main tenets. The first tenet of health financing is the ability to generate revenue. Revenue in the sense that you want to be able to pool some money so that you can have a risk pool that can be used to pay for services, right? The next, of course, is the pooling, where you bring all this money together. And then the third is when you start purchasing services through this pool for a group of people. One of the major problems that we've had is the ability to actually raise the revenue in the way that we should. When you look at health insurance in Nigeria, for example, we've been very unsuccessful over the last couple of years to be able to cover people adequately under a health insurance scheme. And why has this? Because one of the major components of our health insurance bill that has been missing for so long and has recently been adopted is the mandatory nature of health insurance. Because one of our people normally will not, go under a health insurance cover because cultural beliefs, socioeconomic factors that play a role. But with the mandatory nature now that has come into the health insurance law through the NHIA that Mr. President has signed, we may have some success in being able to pool resources through health insurance. However, because of our demographics again, because we have a high percentage of informal to formal sector, the difficulty of actually being able to pool resources at the point of payment would actually be difficult. And it's important that we begin to look at other sources of raising resources to cover the gaps, going into domestic resource mobilization for healthcare. And you start looking at increasing the amount of monies governments are able to pull together to be able to facilitate demand side. Also looking at healthcare efficiency spending. But one of the things that I'm very keen on is private sector partnerships, not in the donor sense of it, but in being able to sweat our assets and see how we can actively generate enough revenue to cover those that cannot adequately pay for healthcare. So there are several issues. You also go to the supply side. It's one thing for you to want to be able to set up a health insurance scheme. It's another thing for people to actually be able to access care where it is required and at the right quality and at the right standards. You look at majority of public facilities, we have several issues with them in ability to, deliver quality healthcare. You look at the private sector, it is highly atomized, it is fragmented, there's poor quality oversight. So there's still a lot of work that needs to be done when we are looking at health financing in Nigeria and by extension in Africa. But I must say that, we should at least give ourselves a bit of kudos because we are now looking at a situation where we can, address some of these issues going forward. I'll stop at that so I can allow other people to have a go. Thank you very much.
Thank you, Dr. Bula. I wanted to introduce a dynamic to that conversation, Dr. Onya. Just before we started the call, Dr. Onya was making a statement with respect to the fact that some countries in Africa are already attaining universal healthcare coverage. They have better coverage of health insurance, Rwanda being one of them. I do know that Kenya has a significant population. However, you talked about the mandatory state of health insurance. As of now, we do know that about between roughly 3 and 5, and that is debatable, in Nigeria, and on the continent, less than, overall, of our total 1.2, 1.3 billion population, less than, 30% of that population is covered extensively by health insurance. So Dr. Oshuni, I would like you to bring your experience, especially around working within the health maintenance organization space, because of, how readily has it been? Because I do know that there was that process where private sector organizations were paying for their employees to be covered by health insurance. How well as this played out as against users coming to mobilize funds or pay for their health insurance, as the case may be?
Okay, well, first of all, let's try and capture the magnitude of the health problem in sub-Saharan Africa. It is said that sub-Saharan Africa bears 40% of the global disease burden, and Nigeria being a fifth to a quarter of sub-Saharan Africa. You can imagine that Nigeria probably bears 8 to 10% of the global disease burden. Now, the healthcare with insurance becomes not a medical issue, rather it's a financial issue. All right, it's now becoming a financial service once it's health insurance. As Dr. Kula just said, the original law, as soon as it was passed, the following day on the 30th of May, 1999, we knew that this law would not suffice. And we've struggled since then to get a mandatory law, which has since been passed, thanks to the efforts of the DG, of the NHIA, and other members of his team and the legislature. So what we have is a potential UHC tool in Nigeria. Unfortunately, Nigerians are not great taxpayers, because that would have been another means of generating the much needed revenue for the service. It's paradoxical that the Abuja Declaration on Health, wherein 15% of the budget of sub-Saharan African countries was supposed to be devoted to health, was passed in this country. So far, we've never managed more than 5%. And I think it's going at about 3 or 4% now.
Yeah.
So on the private side, people say that the gift of the private sector is efficiency, and the gift of the public sector is its sheer size and power. We've only had about, in the private sector, maybe 2 or 3 million enrolled for the past 23 years. So it's not enough. I believe that what we've been doing is a full dress rehearsal for the main event, which is just coming in with a mandatory law, which will scale up the size of the industry 100-fold if we achieve full coverage. So we're at the beginnings. There is hope. Perhaps some of the taxes, sin taxes for sweets and sweetened beverages, which have already been passed, tobacco, alcohol, will help to defray the cost. But the DG of NHIA has given the price for coverage for everyone at 15,000 naira per person per annum, at about, it gives a figure of about 3 trillion. 3 trillion naira will be required to do this coverage. So where are we going to get it? I think that's for Nigeria. For other countries, I'm not too sure of the numbers, but I'm sure the problems are very similar. So, well, that's a little bit for now.
Thank you, Dr. Oshuni. Dr. Onya, while Dr. Oshuni was speaking, he had mentioned the issue of the cost that the health insurance authority had talked about in terms of 15,000. And from your wealth of experience, you know that affordability, you know that there's been issues, relationship issues, of course, with between HMOs and providers in terms of capitation costs, and that is really worthwhile for them to actually be in a relationship with the HMOs. Of course, there've been that back and forth on the cost of services. Now, so looking at this kind of approach, where the NHIA, the authority is saying 15,000 from the concept of affordability, and if you look at as of now, the minimum wage is roughly say 30,000 about naira. How many states have actually fully implemented? I will take 50% of my salary monthly to actually to be able to pay. Of course, it's an annual cost. Then if I'm going to have, the average size of a home in Nigeria or in any African country, averagely you see between 4 and 5 people. How do we then ensure that this conversation around affordability, and I want you to it from a provider standpoint, from a point from the private sector, playing this going to be really affordable on our side as a country, and then reflecting, do we play well as a country with this concept of saying 15,000 naira as the barest minimum, considering our socio-economic characteristics as a people?
Okay, good afternoon, everybody, and thank you for having me here. Nice to be on this panel with Leke and Lamide. Okay, the first thing I will say is 15,000 naira per person, and the amount, the total of 3 trillion that Leke had referred to. I think if we had that pool of money, then I don't think anybody would complain. It would be more than enough, considering that we are a fairly young population in Nigeria. I believe more than 70% of us are probably below the age of 40, more than 70%. So there will basically be very healthy people who will compensate for the unhealthier and older minority. So I think the challenge will be in getting that 15,000 naira per person. Like I alluded to the issue of the sin tax. Clearly, many Nigerians will not be able to afford 15,000 naira per person. But I think, okay, let me flip that. So many Nigerians in the public sector, we have a huge informal sector where people earn a lot more than we can realize. Sorry to say, even the beggars on the street can afford 15,000 naira a month if they think it is important. I mean, per annum, I'm sorry, not per month. Is it per annum or per month? Dr. Shinu,
it's per annum.
It's per annum.
It's per annum.
So clearly, if we break 15,000 naira per annum to per month, that comes to just a little over 1,000 a month. Think about it.
Yes.
There are very few Nigerians who cannot afford 1,000 per month. So the problem is the will. I agree with a fairly poor nation. It's the will. People don't see the need. I'm sure Leke will tell you that most people who are taking up insurance now, the older people, which is a very adverse selection for them. I sit on the board of a health insurance company, so I know. An HMO. So I know. By the time you get to 50, then you start to recognize the need for healthcare. But then that's when you also have all the chronic ailments. So I really feel very sorry for the HMO and the health insurance company. If we can create awareness and let people see the way we have, the kind of awareness we've generated around owning a PVC, I'm talking for Nigeria only now, owning a PVC, and people now wanting to get their PVC. If people could see the benefits to contributing to the health insurance scheme, I think it's doable. But I think to jumpstart it, the government will need to commit a little bit more resources to health insurance. But of course, it's not just about, even if the government is bringing 5% of annual budgets, 5% of annual budget is not a very small amount of money. There's also the issue of corruption. Does the money really get to where it should get? So it's a multifaceted problem. I know one shouldn't throw one's hands up in despair, but I think first and foremost, there are many issues. The first issue is we have to see the need. People have to value health insurance and see the benefit of health insurance and key into health insurance. And then there has to be good faith at the level of the NHIA first, and then of course at the level of the insurance companies as well. And I think with that amount of money available,
thank you so much.
Suddenly, and a huge pool, the proper pooling of the people, suddenly the money will be enough to provide at least primary health care. And I think primary health care is the focus of universal health coverage. I run a primary health care center in a very rural part of Delta states. And it doesn't take a lot to run that center. And it can be replicated in almost every community in Nigeria if there's a will. So the things I see, it's not just about the financing, about the will. It's about the corruption. It's about the people seeing the need for it. So education, enlightenment, people seeing the need for it. I guess we have to start somewhere, and we started in the right place, which is making it mandatory. But then how does the government plan to enforce this? How do they intend to collect money from our huge informal sectors? We are very good with nice policies in Nigeria. Then the devil comes in the detail, I think. I don't know if I helped at all. I'm a little bit...
Yes, I want to move the. Thank you so much, Dr. Onya. I want to move the conversation to Nelly, and I wanted her to share a bit of the Kenyan experience, in this conversation. I know we started the conversation quite just right in the middle, where we're speaking straight about health insurance, because we do know and we do recognize that health insurance is one of the biggest approaches to financing sustainably healthcare, because it then creates, just like what Dr. Onya is saying and what Dr. Litke has alluded to, and what Dr. Kula just started with the concept of mobilizing that financing, that pool of funds that enables us to be able to do so much. Of course, Nigeria is not the only African country riddled with corruption. I do know the scandals that happen in the NHF in Kenya, but one of the biggest things is that I do recognize the fact that there are few things that we often overlook, and we look a lot to the West, right? So I just wanted to give us a sort of understanding, a little bit of landscape about how the Kenyan health insurance sector is as compared to what you've heard about Nigeria. Just enlighten us a bit, but more to the side like just what Dr. Onya talked about, the action and attitude towards the health-seeking behavior and the payment of health insurance processes, payment for health insurance capitation by individuals and companies in Kenya.
Yeah, thank you so much. Very interesting conversation. I'm just laughing because we have similar challenges. So really, Africa is one. But moving to the risk pooling aspect, I think in Kenya so far we have about 15.8% coverage with the National Health Insurance Fund. I think what the government did is, one, it was made mandatory. It first of all started as a cover for civil servants, and then to the formally paid people. So it's actually cut off, the premiums are cut off our pay slips before we, even get our salaries. So that is how they net the formal sector. But then now the informal sector, there are some strategies that, some counties, because again, in our setting, health is devolved, meaning that we have 47 different governments that need to net people from their counties to the National Health Insurance Fund. And I have worked in some of those counties, and some of the innovative ways is they're using community health workers to actually mobilize communities to enroll into NHIF. And we've seen success in some of those counties. percentages going as high as 64% coverage in the national health insurance just by using community health volunteers. And it is part of their performance indicators as community health volunteers to enroll people to NHIF. The other thing is, which leads to the question about the premiums, is that what the government did is that it mapped out the indigenous population, the population that cannot afford the premiums, and put in a budget to actually pay for those people, pay for the premiums. So in that way, it cushions really those retired old people, people who are marginalized, who are not able to afford, and hence they are cushioned from financial hardship. However, definitely the pool is not enough. The pool is not enough. And so we need other creative ways. And we have countries like Ghana that are a step ahead in terms of using VAT, the value added tax, 2.5% of it goes to health. So syntaxes are good, innovative sources of taxation are good, but the question is, will that money be ring-fenced for health? Because what happens is that, yes, we will get that VAT or that syntax, but then, as you know, our government's priorities change. And so the money doesn't go to the risk pool as it is meant to be. So it's one thing to propose for a ring fence, to propose a VAT tax or a syntax, but also another step is to make sure that that money is collected and ring fenced for the risk pool, so that we can be able to increase our risk pool. Insurance only works if the risk pool is large enough. And as Dr. Ngozi pointed, we need more young people to actually get into this pool, and our demographic dividends in Africa allows for that. It would make so much sense to have a huge risk, because we have more young people compensating for those elderly people. But then again, health sector cannot stand alone. When we say people to contribute, do they have jobs? So we need economic stimulus. We need the economies to actually work, so that then people also afford, even the young people, to afford these premiums that we are talking about. So one of the things that we need to do as health, we need to stop speaking as health only, preaching to the choir. There's a need for multi-sectoral collaboration. How are we working with, the digital ICT multi-sectoral collaboration? How is Ministry of Finance seeing health as a development sector? Until we realize that, we will continue having very, very low investment in healthcare, especially from our government. But I think one spanner in the works, Abiola, I would want to put is, yes, the need for education in terms of telling people about health insurance, why it's important, and not wait until you're sick that you're seeking to pay your premiums. But also the flip side of it is that, can we get more money for health from the already allocated resources we have? How much quality are we getting? How much efficiency do we have? I was reading, WHO shows that 25% of budgets that are allocated in the continent remain unspent, surprisingly. Yeah, so we could be, saying that we need more money, we need more resources, but then I think it's also important, and as an economist, always think the other side. Are we being efficient? Are we managing our costs? Are we purchasing health strategically, or are we still passive purchasers of health, where we're just allocating budgets based on historical figures? Or are we intentional on who is the provider? How are we paying our service providers? How are we compensating our physicians? Issues of capitations, issues of diagnostic related groups. We need to really think about these things, because I always say health financing is the icing on the cake. I think the baking, the foundations, the policies we put in place, the structures and how we think about it is even more critical. So I will pause there. Happy to speak more.
Thank you so much, Nelly. Thank you so much. Thank you so much for that perspective. I want to come to Dr. Nelly. And interestingly, while Nelly was speaking, she spoke about efficiency around spend. And quite interestingly, and this the question I had sort of reserved for Dr. Ine because he sits, he's more, and he now sits as a DG for the Contributed Health Scheme in Ondo State. One of the things we see, right, is the fact that the government goes out to, to purchase, care, right? But what I've seen within the healthcare space, or within the space when it comes to health insurance or state health insurance schemes, is that the first point of call for purchasing care is actually the public sector, right? So is that not, and there are two questions here, is that not sort of, are we not sort of looking at it as we are disenfranchising ourselves because we do have a pool of private sector providers that are in the states or in the jurisdiction that can also provide care, but I already have frameworks of quality and the likes while we're still upgrading our facilities or we already have upgraded them? Does it not create a lack to be able to reach more people? And the other side of it is that, in terms of efficiency and from your experience, how would you describe, just switching from that private sector approach into government where everything has to be methodical, and then you have a lot of approval processes, in getting, what you would have called your budgets for getting certain things done? I would like you to speak to that, Dr. Ine. Hello, Dr. Ine.
Yeah, kindly allow me not to put on my video so I can stream better.
Okay, fantastic.
All right, thank you very much. The first one talks about focusing more on public facilities rather than engaging private facilities. We all know that over 70% of care are actually being provided at the private level. And the way the health insurance is actually designed across the 36 states and FCT currently is people have the prerogative of actually using either a government hospital or a private hospital. The aspect of it that government concentrate on public facilities is when they have the equity scheme. So when they have a scheme for vulnerable group, maybe for ease of administration, and because the volume of resources required is not that huge enough to attract patronage at the private sector level, then they tend to turn to public facilities because they already have line budgeting, the wages of the workers are already being paid, so that the icing on the payment is something that is acceptable, which private hospitals may not really be in tune to accommodate because of the large overhead that they bear. The other aspect you mentioned is about efficiency at the level of the government coming from the private sector space. Most of the health insurance agencies across the 36 states and the FCT currently are agencies that are either semi-autonomous or they are independent of encumbrances of government. And that's why it makes it very easy for them to be able to carry out their work efficiently without having to go through the bureaucracy that we see in public service. But there is a good news that I would like to share with the people here today, is the fact that because we have not really updated our records on the coverage of health insurance in Nigeria, as at the last count when we had an engagement with National Health Insurance Authority, we were able to aggregate the figures across the states, the number of enrollees that have actually keyed it into the health insurance space under the state social health insurance system. And you'll be amazed that we have over 8 million enrollees that are already being brought in at the level of the states. Currently, there are about 34 states that actually shared their numbers, either through their formal sector, informal sector, the basic healthcare provision fund program, the state equity program, and the tertiary institution health insurance scheme. And we have over 8 million, and that's roughly looking at almost 4% addition to the 3% that NHIS already have. So by accumulating this, we have over 7% of Nigerians already on one form of health insurance or the other. And that's roughly about 14 million people. So we're on the right track. And like the previous speakers also mentioned, the NHI Act, making it mandatory now, strengthen what the states are already doing, because most of the state laws already embedded in their laws that health insurance is compulsory. And Dr. Oye actually asked, how do you enforce? Now, we need to be innovative, and that's the word I would like to leave with us today. There have to be an innovative strategy on how to bring people in. 15,000 per annum is roughly 50 naira a day. And most Nigerians actually earn their wages on a daily basis. So asking people to pay 1 year upfront is one of the potholes I see that quite a number of people have. Now, it's not that they are not aware of health insurance, but they are not in tune to make this commitment on a one-off payment. So if we create an innovative way to allow people to make payment on an installmental basis, on a daily basis, then more people will come in. And insurance is a game of number. Until we have the number, then it will not be attractive to private providers to be able to do business with health insurance practitioners. And how do I look at this? We always talk about private sector engagement. We need to involve the banks. We need to involve the microfinance banks. We need to involve the telecoms. Hardly do you not have somebody having a phone. And if there's an innovative way, you know, NHIS was actually looking at having what we call the telecom tax, which did not sail through in the act. But we can revert it and have an engagement to say, can we have direct debit deduction without encumbrances of telecoms asking for 30% charge? So if we remove that pothole of removing 30% of every contribution that passes through the telecom, or maybe 50% by the time you add layers to it, then it becomes very easy for people to come in. Quite a number of microfinance banks already have huge number of patronage of people that make daily contributions, because health insurance agencies don't have the capacity to do collections. So if we partner with banks, with microfinance bank, with telecoms, that this thing can be done taking advantage of electronics, then that will make it easy. I'm aware that there's a telecom company currently having what you call the e-wallet, electronic wallet. So if people can have electronic wallet, then money can be taken from the electronic wallet to pay for the health insurance in a way that is convenient for them. You'll be amazed that artisans buy recharge cards upward of 500 a day because they buy on installments. Every 2 hours, can you get me a recharge card of 100 naira after making a sale? A vulcanizer, after making a sale of 500 naira, can send his errand boy, get me a recharge card of 100 naira, and he can repeat that about 2-3 times in a day. So that means this person can actually contribute 50 naira a day. But the problem is, how do we aggregate it? How do people make those collections? We are so big and diversified. So if this person is either attached to a telecom, or either attached to a microfinance bank if it's unbanked, or either attached to a bank if it's banked, can there be a narrative around how these things can be done without any encumbrances of the person? And the person doesn't really care if you take 15 naira from the recharge card that he purchases in a day. So I believe that innovation is what we need to take advantage of. The numbers are there. 200 million people is almost like 5 countries in Africa. So we need the large number for the health insurance business to make sense. And like somebody mentioned, if you have 3 trillion being pulled into both government and private hospitals, they will become centers of excellence. So let me stop. Thank you.
Thank you so much, Dr. Yunei. And while you were talking, you spoke about conversation around innovation and the financial services sector. And then quite interestingly, you have Adewale here from Sterling. And I would like him to share a bit more as regarding that. We do know that, Sterling and your experience within the financial services sector, there are quite a number of things that you work around. And do you think the proposition that Dr. Inei made is something that is possible, considering our, if you let me say, nascent adoption of digital technology, which is growing very fast as compared to, Kenya, where M-Pesa is literally powering the entire economy, because our society is such that the bank is ahead of the telecoms. In Kenya, it's as if the telecoms with the M-Pesa process is actually driving a lot of economic activities. Adewale, please.
Okay. Thank you, Abiola, and thank you for all the speakers that spoken earlier. I've been listening attentively, and I think a lot of the issues have actually been mentioned, and I'm particularly happy with the suggestions of Dr. Oyene. And truth be told, we really do not have any option than to toe those lines. And towing those lines means that we need to have a very robust engagement across board. We must be deliberate if we are actually very serious about universal health coverage. Being deliberate means that all of the people, all of the folks that needs to be engaged need to be brought into the conversation and have proper, robust conversation. You see, funding is a different thing, access is a different thing, and then there's also the collection part, which Dr. Oyene had mentioned. And fortunately or unfortunately for us, you have an informal sector that is over 70% of our population. And sometimes I remember when we were, trying to look at agency banking and how to bank the unbanked and all of that, the misconception people had was that people who don't have banking relationship probably don't have money. But that's a lie. There's a lot of money revolving around the informal sector. They just don't have access to financial services. They just don't have access to, the banks, to have a formal financial relationship with any bank. We've been to places where you see people, collect cash, they display cash, they keep the cash over there, and then people come in, do their transactions, that way. And these are the things that we need to begin to find a way to incorporate into health insurance. Health insurance, like everybody had said, basically, is for us to be able to pull that fund together. We can have a conversation around spending and utilizing the fund, but how do we pull that fund, together? We mentioned the fact that people, get their financing on a daily basis. And what are we talking about? We're talking about artisans on the field who makes money on a daily basis. How do that individual have access to be able to pay for his health insurance? And unfortunately as well, which are the things that I also mentioned, the fact that we need to begin to engage. The providers, on the supply side also needs to give in to some things, in terms of how people make payments. Dr. Ine has alluded to the fact that state says, oh, it's 15K per annum for you to pay. How many of these folks can actually brought out 15,000 naira from their cash flow in a day and say, I'm paying for this health insurance? So as we're expecting, when you know your customer, then you should have it better, because the first thing for you to do is to strive to know your customer. When you know them, then you know how to deal with them. Somebody who gets his money on a daily basis, and that's why it's, in financing, what we tell our people is that you need to also tailor your services to the business of your customers. Because it doesn't make any sense if you are going to meet the customer with the customized products that you have for a different sector, and you bring it here and you expect it to work for that particular customer, it won't work. So for health insurance specifically, and I'm glad that there are a lot of agent banking network that we have that are coming up with different innovative way of reaching out to people and being able to collect premiums and make people make their remittances to the government for those kind of activities. And that conversation, especially with the telecoms, needs to happen. Like you mentioned, virtually everybody anywhere across this country has access to mobile phone. Virtually every village has a small store somewhere, or a kiosk or a malam kiosk who exchanges goods for money and all of that. These are the people that we need to incorporate into the collection activities around premium.
Fantastic.
What are we doing with the trade unions? What are we doing with the market associations who have all of these in their fold, who have all of this under their control? If, for example, we go to a motor park and we are talking to the leadership of that motor park, and they make remittances on a daily basis, compulsorily, yes. They do it, So how do we incorporate them into the whole aspect of funding for health insurance? And I often tell people, see, you need to engage. And how you engage is to also let them realize the fact that this is what health insurance will bring to you. You can imagine on a daily basis or at any time you fall sick, you go to a hospital, you are not bringing out a kobo. You are not bringing out any money from your pocket for you to have your treatment. So what will happen is that you fall sick, you close your store, you go to the hospital, get service, and then you go back home, rest for the day or two, and you come back, and you're fine. Your business continues, you are not owing anybody and all of that. But if you don't, what will happen is that you probably go to that hospital, the sales that you have made for that day, you would use it to pay for your services. Then you will borrow money for you to be able to feed as you are, recovering for a day or two. When you go back to your business 3 days later, you are in debt already. So when we begin to, engage them and explain all of this to them, then they begin to also realize the fact that I need to pull aside this money. I need to be able to have this, because sometimes when you go to meet, states, to meet agencies, everybody keeps saying, oh, banks, bring money. Can you come and support us? What are you going to do for us? Put us as part of your, how many of our CSR plan can we do, across all of the states, across the country? So we need to be deliberate with our engagement to be able to have that collection. Like you mentioned, M-Pesa probably have, Kenya probably have a hedge, over us in terms of being able to collect payments from the people, especially from the informal sector, because of the advent of M-Pesa over time. If we can have a way in Nigeria of converting airtime value to naira or to money value for health insurance, I'm sure we will cover more than 50% of the problems we have in being able to pull resources together in the informal sector. And then we can begin to engage all of the associations, all of the people that controls the different businesses and the different engagements that they have, and being able to pull those money in place. And yeah, on the formal sector, we also have some problems. For the corporate bodies and for the organized private sectors, it's easier. Your employees can make it mandatory on you. For all of you are in our employment, we are taking this as your premium for health insurance. You have been subscribed to health insurance, and that's easier to take. Now, when you go to the public sector, what you also see is a whole lot of tussle between maybe the unions and the government, or the union and the health insurance agency. You need to do a lot of advocacy, and we have to bring them on board. Their fears are valid, but we must be able to allay their fears. And the only way we can also do that is to begin to imbibe the public-private partnership that will aid quality service delivery. We've mentioned the issue around access, affordability, availability, and the accessibility of healthcare. Another very important one is quality. What are they getting? If I get good quality for my health service now, I'm eager and I'm willing to be able to pay for more, because when I know that when I come back, I'm going to get more. So the providers, or those who are the supply side of this, also needs to be able to adjust and ensure that they are providing quality service to the people. So the banks are ready. There are different agency networks that are being that are coming up and springing up everywhere across the country now, to the extent that you can actually deploy agents to some of the remote locations, across the country, to be able to collect, actual value from people. So the government just needs to, or the state health insurance agencies just needs to come together, engage all of these folks, and then be able to have access to those funding from the people, while also guaranteeing that they have quality access to healthcare service delivery. Thank you.
Thank you, Adewale. But you mentioned something that was very critical, and it's been going on in the conversation. And I hear this just a summary. We have the infrastructure within the banking and telecom system. We need to engage it. We need to be able to engage the private sector, and that's one thing everybody has spoken about. We need to create a lot of disruptive, collaborative approach, the informal sector, and ensuring things are somewhat coordinated, because we already have a sort of framework in country, in Nigeria and across the continent, where the informal sector is sort of doing a daily kind of contribution system. In China, they call them the chamas. They are like cooperatives, and they work a lot. They function very well. I want to bring up this conversation around the issue of taxation. Taxes actually are one of the biggest, aspects or sources for us to be able to do a lot of healthcare financing. or we can channel funds into healthcare. Recently, Nigeria introduced the sugar tax. Of course, beyond the, and I don't want us to dwell around corruption a lot, but one of the biggest things I've seen here is, in Kenya, I think the tax is about 17 or 18%, and quite a number of, in Nigeria, our VAT is still 7.5%. Of course, we do have, a sort of multiple taxation regime. Do you think, and I'll begin, from Dr. Leke, Dr. Kulaja, and I would just like to hear your viewpoint. Do you think that we can, recalibrate our taxing regime? And I would like you to speak to from the concept of, the taxation level, the collection level, and that ability for us to be able to mop up, as much money from our taxation and then channel it correctly into the health insurance space.
Okay, thank you very
Dr.
much.
Leke.
Yeah, one very useful figure for assessing the tax compliance of a country is the tax to GDP ratio. And in Nigeria is in the region of 6%. Is at par with countries like Afghanistan, Central African Republic, Benin Republic. So when you compare it with countries in Europe like France or Denmark, who are doing numbers approaching 50% of GDP as tax. Now, Nigeria's GDP, well, it varies. We usually do it in dollars, but with the naira falling against the dollar, it's probably in the region of 400 billion purchasing parity dollars. Now, if you had even 10% of that, that would be $40 billion we're getting from tax. Right now, our national budget is in the region of $25 billion, which is the same it was in Shagari's time. I don't want to embarrass you, Abiola, but about the time when you were visiting the earth. In that time frame, the population of Nigeria has increased threefold. And we're still spending the same amount of money we were spending in 1979. It's estimated that certainly less than 20 million Nigerians pay tax, which is 10% of the country. That's the payee tax, and then you have the corporate taxes, of course. So there's just not enough tax money coming in. South Africa has such a much better, South Africa collects more tax than we do, even though their population is a fraction of ours. So first of all, we have to widen the tax net. And then we have to deepen the tax net. And I don't want to call Nigerians tax evaders, but you could use that kind of term. They're not tax compliant. So to raise significant sums of money, you need that tax has to come in and come in hugely. The VAT regime is an attempt, but when you consider that the VAT in the United Kingdom is 17.5%. compared to ours, which is 7.5, maybe we need to take another look at it. So yes, tax, pay tax, and then people need to have jobs also. Formal sector jobs, and then the informal sector, like Dr. Onyeka said, a lot is dropping through the cracks in the informal sector. People are quite rich. There are traders who take in several million naira a day who don't pay a penny or a dime of tax. So we need to look at these things. The DG of the NHIA has said he has the assurance of the topmost tier of government that 83 million vulnerable people in Nigeria will be covered under the NHIA Act. So he's looking for 1.2 trillion for that. If the telco tax had been implemented in the first year, it would have given up 90 billion naira, which is still a far cry from what the 1.2 we're looking for the vulnerables. So we need to sit down with these numbers and see how we can make them work for us. Otherwise, it won't take off the way we've envisaged it. On the issue of using airtime as premium, we've tried that. In 2014, quite a few $1 million went down the drain when we tried it with MTN in a scheme called Yellow Health. Failed because of regulatory capture. at the time, after a lot of money had been spent. MTN was going to do it because MTN had seen the M-Pesa example in Kenya and wanted to replicate it in Nigeria. So there's so many ways to dice this huge problem. It's a work in progress. Thank you.
Thank you, Thank you, Dr. Oshuni. Dr. Kulaja, I'm going to come to Nelly to share the Kenyan experience for us. One of the things, of course, you sit very closely with the Honorable Commissioner for Health in Lagos, and you've worked a lot across the country, from the AUHC and the likes. I just wanted you to kind of share your experience. How does Lagos do it? Because sometimes I look at the high-flying nature of Lagos in terms of, and especially, I remember the Ebola, I remember the COVID response, and it seemed like Lagos became a stellar example, if you let me say, comparable to other places or other countries. I also remember the Californian and New York experience. How does Lagos do it? Because, of course, as much as we still have a significant population that not in the informal sector that are not able to remit tax, how is that significant population of Lagos, how is Lagos able to do that process of being able to mobilize the right amount of resources and then allocate the right some good resources for healthcare that seems to be a lot more upscale in Lagos? How from your experience interacting within government, how is Lagos able to put that mechanism in place?
Thank you very much, Abiola, for that question. I think one of the things that I can say it's not a function of how Lagos has done it, because Lagos does have a lot of things going for it. The first thing is that Lagos is the commercial hub of the country. Most of a majority of the biggest companies in the country are, their headquarters are in Lagos, right? And so there's an ability for Lagos to be able to generate some level of IGR that does not exist in other states. So that in itself has created a boon to Lagos revenue generating capacity. However, the same issues that plague other parts of the country also plagues Lagos, because even though they're able to generate huge IGRs, Lagos is still a destination for a lot of people looking for greener pastures. And so a lot of arguments have actually come up to say even less than, that we're even more than the 24 million people that we say we are. If you look at the number of slums that have increased in Lagos in the last 10 years, they've moved from 60 slums to about 660 slums. So we also do have major issues in Lagos that requires attention. There's really nothing else to add to what Dr. Oshuni has said regarding the tax issues. However, one of the things I just want to add is that, most developed countries have moved from an era of industrialization to an era of financialization, right? Where we begin to look for resources to cater to some of the issues that we have, separate from taxation, where government begins to look for alternative sources of income to fill the deficit in the gap that exists from the lack of ability to tax effectively, which is a huge problem. I mean, when you talk about tax, you have to first of all talk about the ability to, effectively and easily tax, which happens when you have a population that is, largely formal. Again, even if you then don't have that, it's then what kind of tax are you collecting? Are you collecting a regressive tax system or a progressive tax system? Is there some level of equity in your taxation? Are you putting more people into financial hardship by implementing these taxes? So those are some of the issues that exist with that. So in my view, I think that one of the things that government needs to do is to begin to look at alternative sources of income beyond taxes. The amount of monies that are being spent, the administrative costs involved in collecting premiums and collecting taxes from the informal sector is actually more than the taxes that we are collecting, right? So why waste that money? Why don't we begin to look at other sources of domestic resource mobilization to see how we can then raise financing to cater to some of these issues? If we're able to do that, then we might begin to see some kind of progress in ability to provide adequate financing in the country. Again, Lagos is looking at several interventions, some of which the Honorable Commissioner is going to reveal over the next couple of months. And these are the directions that we are going towards. We are looking at a lot of private-public partnerships. We're looking at government, delineating the clear roles and responsibilities between government and the private sector. We are looking at complementary partnerships as against competitive partnerships, competitive roles. So it's looking at what is on the table and putting all the pieces together and mixing it in a pragmatic way to get the best outcome that we can. Technical efficiency, if you might put it that way.
Thank you, Dr. Kulaja. Nelly, I come to you, just for the Kenyan experience just a bit. I do know that I've heard a lot about this, that, filing taxes is a big deal in Kenya and people take it very seriously. Was it always like that? So that's one. Two, in terms of, I do know when we started talking about devolution, of course, in Kenya, there was that issue of how, allocation of taxes were going to be in Kenya, particularly for healthcare, and it seemed like for some point it was somewhat centralized. Then, then it changed again to being devolved, where you have, the county committees that are basically managing sort of the county budgets, which is similar to what we have as states in Nigeria. And, that's kind of similar to what you have across Africa. Now, for me, what I would like to really ask is, what was the magic wand, if you let me ask, and if you can provide some insight that Kenya kind of used to get people to begin to remit taxes and then begin to think about how to ensure, because there seems to be an urgency in the average Kenyan's mind that, I must remit my tax, I must, do my filing every year. How did that happen? Share that experience with us.
Yeah, for sure. Actually, the financial year 2020-2021, for the first time, the Kenya Revenue Authority exceeded the tax collection and hit the 2 trillion Kenya shillings against a target of 1.8. And this is post-COVID. So that was really commendable by the taxman. But in my view, what this meant was, one, the government has really made huge efforts to digitalize everything. The companies are registered online, so you file your tax. You as an employee, you file your tax online. So that whole digitalization process closed a lot of loopholes where people, in one way or another could evade taxes. That has become quite difficult now. I think also educating the masses and the populace. KRA now ceased to be that building we knew that was somewhere in the corner of town, to them setting up stations, in the streets, in strategic places, and having taglines of why taxation is important. And in Swahili it says, kulipa ushuru ni kujitegemea. When we pay taxes, we are able to be self-sufficient and self-sustaining. So that also has changed the mindsets of people. But then the other one is the carrot and stick, where they are quite aggressive in collecting taxes, and there are fines. So by 30th of June, if you haven't done your pay as you earn tax, you're sure to get a 20,000 Kenya shilling fine. No one wants to lose that. That's about $200. And so we make sure by the 30th, of course, even system starts failing by 30th or 29th, because all of us will do it last minute, but that has also worked. But also now, looking at that, and then in the health context, also the political will around healthcare, because our outgoing president had health as part of his agenda 4, really also pushed the allocation of these taxes that we are talking about to be allocated to healthcare and to support universal health coverage efforts. So I would say the two things going hand in hand has seen an increase in investment in universal health coverage by increasing our health budget, but also more importantly, investing in primary healthcare, which we've seen in the last couple of years. Yeah.
Oh, thank you so much. Thank you so much. That's quite an interesting experience. I do know that we do have, the carrot and stick in Nigeria, but how efficient that is also still very questionable. I want to come to you, and I want to go more granular with respect to conversations around raising financing in Nigeria, especially for healthcare providers. And you're a veteran around that. And just so I just wanted to announce to our attendees, our participants, please, you can also send in your questions, so we can also bring it to the fore for the panelists. In Nigeria at this time, I do know that the cost of financing is high. Adewale is on the call. You can on the panel. You can also tell us what it means to actually go to the bank as of today. Is in double digits, right? What has the experience been? On the last panel, we had someone talk about the idea where we need to find alternative ways of getting monies into health. And, recently we've seen a lot of investment from outside the continent into the continent through VC approaches and direct, foreign direct investments. But they are not like, what you would have said are the approaches that you would have looked at, the traditional approach of walking to a bank and get money. How has the experience been? Maybe I should rephrase the question. Share a bit about the experience, but more about what do you think can be done on the continent, especially, of course, in Nigeria, around access to finance for businesses that focus around healthcare. I think let me phrase that question properly that way. Dr. Onya.
Okay. Olamide had a lot of experience on access to finance, I think. Certainly, healthcare-related loans should be as cheap as is reasonable for us. But the truth is, I'm sure Mr. Adebowale will not agree with me, but the truth is that they're not. So personally, most of the funds I have used to grow my business have been from friends and family. That's the honest truth, which is literally working with your sweat, your blood, your tears. It takes its toll on you. Accessing funds, the margins are already very thin in private healthcare. Dr. Oyenenyi referred to the massive overheads we carry. So the margins are already very thin, maybe in the neighborhood of like 5%. And then you're accessing funds for 10%. If you're lucky, that is from the Bank of Industry. And if you're not so lucky, you're accessing at between 18 and 24% from banks. They will require collateral. A lot of healthcare providers, MDs of hospitals don't own any collateral. They don't have collateral to give. That's the honest truth. The banks are not willing to accept equipment that they finance as collateral for good reason. They're not able to resell them in the case of default. So there has to be. So I guess that's the reason why people are now looking into venture capitalists and people like that. That seems to be working, and I think it's fine. The problem is that means that, of course, ownership shifts from the hands of Nigerians to these foreigners. And there's nothing we can do. But if that seems to work without giving people too much sweat, then it is what it is.
Then the question is, and I'm going to come to Adewale in a bit. I just, speak to Adewale right there, and I just wanted you to respond to that, Dr. Onya, briefly. It then means that is it then possible for us to then look at, you've talked about friends and well-wishers, then creating a sort of, if you let me say, what British Petroleum created when it was going to go offshore, where it allowed the British people to basically, invest in it and then use that investment to actually grow its offshore approach. It felt like the friends and family of British Petroleum today that we know as BP and the rest of it. And don't you think that might be a better approach? Because we do, I was looking at the numbers of billionaires that we do have on the continent. Funny enough, the first 2 or 3 billionaires are actually from Nigeria. So it will be quite interesting that, you see, is there a way we can create a sort of, should I call it a healthcare endowment, right? That may be a mix of philanthropy and the likes that can then create what you kind of said as a a single digit. It could be a loan grant style system, if you let me call that. But that is self-sustaining in such a way that when it is returned, it creates a recyclical process. It might be managed by a trust fund, by a bank, it can be, but at least it's so low digit. Is it not possible for us to think about things like that? Or has things been done like that before that failed? Or, just share with us, Dr. Onya?
Are you talking about angel investors into your business? Or, well, okay, so two things. One is angel investors. Unfortunately, they don't exist. So even when it's friends and family, they will own a share of the business, okay? But then I know Dangote did give some kind of funds to the Bank of Industry for them to be able to give loans at 5%. Because when we talk about single digit, 9% is not really a low figure. It is not a low figure. When you think of the margins in healthcare, yeah, it's not a low figure. So, but even that loan the money was given to the Bank of Industry, but when the loans came to us, they didn't come at 5%. So yeah, I guess it will work. If it's done. One of the problems, I was thinking about some of the discussions and why people will be very skeptical about paying taxes. There's an issue of trust, and for good reason. If people were sure that they will pay their tax and the taxes will be used for what they are meant for, more people will be willing to pay their taxes, I think. And again, this now brings again the issue of private-public partnerships, because for some reason, the private sector seems a little bit more trustworthy and a bit more efficient, more transparent in the way they do things than the public. Maybe we have from Mr. Adebo.
Yeah, thank you so much, Dr. I'm going to come to Adebo right now. Dr. Onya spoke about the cost of financing. You knew I was going to come to you around that. And I just wanted to share, right? Why does it seem like the cost of finance, and this is not just in Nigeria, the cost of financing, is it not something that we can also then look at and say, maybe we have, if you let me say, special criterias, because of the development of Africa, and and the banks are doing business. Of course, I do know that the banks should make money, or the financing partners should make money. Why is the cost of financing that high? That's my first question, especially when we're considering for healthcare. And in terms of creating models, what do you think and this might sound very funny or out of place, but what do you think would have been more prescriptive, for helping to improve access to finance, particularly you understanding from on the inside? I know the CBN at one time during the COVID did the endowment fund for people to access. Till today, I still try to find out how many healthcare organizations were able to access it. Is it a function of policy, or the policies do not consider the context that we're in, or is it that people are not just able to meet those criteria, or just like Dr. Onya just rightly said now, is it a function of trust, that we don't even trust the system enough to even engage enough? From an insider point of view, please share with us.
Okay, thank you, Aviola. And see, everybody is spot on. And financing, basically, and healthcare financing specifically, we cannot totally isolate the issue of healthcare financing from the macroeconomy, and policy of the country. And I'll tell you a situation where, first of all, money from the bank, it's not magical money from anywhere. They are monies by depositors, money by you and I, and that have their monies with us, that will require it at any time, that have placed money, for a certain period of time, expecting a certain return. And then we have policies in place where some part of that money needs to be reserved in the CRR, the NDIC, deduction that you need to do. So invariably, at a time where you say you have hypothetically maybe 100 million naira deposit available to you, and you have a certain percentage reserved as CRR, you have what you have for NDIC, what you have in terms of valuation of that money is probably less than 70 or 60% of the money itself that needs to yield the total value for 100%. And all of those comes to play into what the margins for financing comes to eventually, and that affects that, and it's just a general condition as a country, and you can't have facilities in single digits from any bank, across the country. And what we have tried to do, for us as a bank, is also see how we can find innovative ways to alleviate the businesses, especially in the healthcare sector, to the extent that Dr. Nya mentioned the fact that, of course, medical equipment, we all know how volatile those are. We all know how they are in terms of second-hand value, if you're able to realize that when you use that as collateral. But that's what we do. Even for projects that runs into billions of naira, we still take the medical equipment as a collateral for such a facility that we provide. Just to be able to also provide some support to the sector. And then we also have uncollateralized facilities, up to almost 10 million naira, where you don't even need any collateral for you to be able to access that, And those are just some of the innovative ways that we have tried to see how we can reduce the burden on healthcare business generally. And then, of course, we need to look at healthcare business itself being packaged in a manner that attracts funding. It's one thing for you to need money. It's another thing for you to be able to access money. And you mentioned the CBN intervention fund during COVID. I know that that fund, actually existed before COVID. What was called the DSSR, funding for healthcare at a time. How many healthcare facilities, how many healthcare businesses have the requisite documentation to be able to access this funding? That's one thing. I was talking to a customer earlier today, when we were discussing those distribution around pharmaceutical products and all of that. He's been in business for over 10 years. And then I say, what can we do? Let's see how we can support your business. What do you have in terms of records? He apparently has records on papers. He has some that are in some Excel sheet somewhere that somebody has typed in. I said, okay, we can still make do with that. What about your financial records? We realized that it was just about 8 months ago that he begins to run his corporate accounts. He runs the business entirely on his personal accounts. Wow. So those are some of the challenges. And I tell you, it is not about availability of money. It's about supporting business that have sustainability, business that guarantees that you are going to have your money back. If I'm guaranteed that my money will come back, we can always have a sit chat around what the rate will be, what the margins will be. Sometimes what we even do is that when we meet people, when we meet customers, we don't discuss rates, we don't have rates. All we want to do is how your business is run. When we look at how your business is run, we can come to an agreement on the kind of margin to charge to be able to sustain that business. It's our understanding, and that's why somebody like me, and other members of the healthcare team in Sterling are in place. We have medical doctors, we have people who understand healthcare, people who understand how the business is run, so that we're speaking almost the same language with you while we are imbibing you and bringing you into the fold of financial services. And those are some of the things that we've done. And even in certain instances, when we even see businesses that we realize have potentials, we also invest and take equity investments in such business. And there are a lot of all those businesses around our environment, just because we have seen that this business is being run adequately by professionals who have potential to grow. And then we put our money in it and say, let's do this together. My advice generally is for the healthcare sector to prepare itself for financial services. We're going to need this. This inflation rate is going to take a reverse turn, sooner than later. And then we must be available. We must be ready to be able to access it. I was discussing with the NMA 2 years ago. That's even when we're talking about the CBN intervention for that. A meeting with the NMA and AJPMP and officers who says even at 5% is too high. And I said, I understand you completely, but even at this 5%, can we even start? Can you guys come together and let's even pull it together and say, let's have access to, this fund at 5% rate. If I tell you the outcome of that, a whole lot, a larger percentage wouldn't even access that funding because they don't have the requisite documentation. So all of this needs to be in place, and we are creating a lot of advocacy, to be able to ensure that they can actually have access to funding. Sometimes we even appoint financial experts to help them review their books, to help them prepare their books so that they can actually have access to funding. So those are just some of the ways that we're doing to be able to alleviate the burden on the healthcare business. And like you rightly know, we're also going into partnership with the government to ensure that we can, provide succor to the services rendered by people and bring in the private sector as well, because we position ourselves in a manner that we don't even want to look at your problem as financial. And sometimes that's another thing. When you engage businesses, you realize that what they need is not money. They probably need other experts or other introductions that will enhance their business. So, for example, somebody who deals in wholesale distribution of pharmaceutical products, and we have manufacturers who are in our books that can actually provide you with stock that you pay after 30 or 40 days. So when we sit down with you and have that conversation, we can do those introductions, we can midwife such relationship and put our own trust in between you guys and ensure that we trust you, but you guys are not going to talk, but we can put ourselves in the middle and say, run your businesses through us, then you will see that you can deal effectively. So those are some of the ways that we are trying, because we understand that margins are thin in terms of healthcare service delivery, but the margins are high in terms of healthcare financing available, in the private sector. And we were able to provide that. And just to also mention that even in health insurance, we have products that are specifically geared towards individuals who need to have access to health insurance that they can actually pay on a monthly basis. And they can pay as low as 1,000 naira a month and have access to quality healthcare service. And this is based on our engagement and collaboration with HMOs, in the country, just to ensure that people have access to quality healthcare. So those are some of the things that we do in the bank, and we're always ready to sit down with you and have engagement around our business. Once we understand the business, we have a plan that is sustainable in your business. We ensure that we can provide the funding that will ensure that the business keeps afloat and it runs sustainably. Thank you.
Thank you so much, Adewale. So I hear a lot of interesting things, from just this conversation around personal financing for healthcare providers, and that's really about basically building a business that has a business plan. It has records that are verifiable by the financial services. It's not for just the lack of finance, because what we're trying to look at is from a government side or from a more macroeconomic side, the smaller components. So we've dealt with the conversation around, taxation, better provision of allocation of resources from government. We're now talking about the individual private sector organizations that are, talking about the concept of higher percentage of access to finance and the limitations that we have. And so I want to switch a bit to the public sector conversation in a bit, and I'll still come back to Nelly in a bit. And I want to speak to Dr. Yunei and Dr. Oshuni. Now, what are the alternative approaches, right, that you think we can use both as Nigeria or, as a continent, that we can use to basically buffer up, our financing, the non-traditional approaches that we can use based off of the experience and expertise, both within the HMO space and as medical practitioners and your, wide range of experience and contact globally? How can we raise better financing? As of today, I know that the international development community puts a lot of money into healthcare in Africa. However, based upon the total volume of even out-of-pocket expenditure of Nigeria, we can very much say a lot of people spend more money personally into healthcare in the overall context, comparing to what the West is giving to us. Then how can we begin to appropriately, buffer up, in non-traditional approaches, financing in healthcare in both the, private and public space? Dr. Yunei, please. You're muted, sir. You're muted. You're muted.
Thank you. I think where we are currently is there is need to declare a state of emergency in the healthcare space of Nigeria. One of the previous speakers mentioned service delivery. One of the things that attract people or keep people renewing their health insurance policy is if you get value for what you are paying for. And with the exodus of healthcare professionals now, there is so much problem that we need to deal with. And I must commend the president for signing into law the NHIA Act. And the question to ask is embedded that 83 million vulnerable group will be taken care of. Because if you put it in clusters, there are those that can pay and there are those that cannot pay for health insurance. Either they are not gainfully employed or they are below the poverty line. So 83 million people require a lot of resources. Where is government going to get it? So we need to continue to mount pressure on government to fulfill their obligation of budgetary provision. And they have said that for them to increase financing to be able to fund these 83 million people, which costs a lot of money, that there will be provision for health insurance levy. How that is going to be done, we've not been told. Then there will be a special intervention fund. There will be return on investment. Of course, NHIA over the years warehouse money, and there's provision for them to invest this money either in government bonds or other investment opportunities to generate more resources that they can plow back. Grants, donations, gifts, voluntary contributions, because if you look at how the basic healthcare provision fund program was structured, it's meant to be 1% consolidated revenue for federal government. States are supposed to match it up with 25% counterpart funding. So there has to be advocacy at the level of the Nigerian Governors Forum to ensure that more states actually fulfill their own part. Bill and Melinda Gates Foundation in the past have contributed money, and they are also still committed to raising more funds, Dangote groups and stuff like that. Now, if you look at the trajectory in the country, diaspora remittance is also a huge amount of money that comes into the country. So we need to look for innovative ways. If I live abroad, I will be willing to pay health insurance for my indigent family, so that at the end of the day, I will be off the hook of every time that people need medical care or have to pay for medical services, then they get a phone call. So there has to be a way to be able to mobilize the diaspora community in terms of sensitization and also more information on how they can also remit on behalf of their indigent family. There are hardly any family in Nigeria that does not have one or two people living abroad and doing well. Now, there are other ways I believe that funds can also be raised. It may not be sustainable. Anambra State have tried it, the adoption model. You see philanthropists just taking care of their communities. I've seen Osopadek, Desopadek, because these people cough out a lot of money to take care of people when they are really in their need of medical services. So it's even more cost effective to prepay on their behalf and take care of them. Now we are also praising the NHIA Act to say it's now compulsory. And the question is, how do we enforce? So it's a journey, but we can start by having what we call a gentle push. Now, hardly do you have a vehicle that does not have a health insurance cover. At worst, a third party. Now we need to have a way of embedding statutory conditions. Of course, it will have to be in layers, not just something that you start at a go. You take it in strides to say if you need to do certain things, if you're a government contractor, if you need to get an international passport, if you need to maybe apply for a visa or whatever, those are just interesting examples. You need to show evidence that you have health insurance. And if we have all those low-hanging fruits here and there, you will be shocked that there are quite a number of people that have the resources to be able to procure, but because they can pay out of pocket, they rather go the out-of-pocket way than going on health insurance. So if you make it mandatory that before you get a government contractor, a state contractor, you are involved in certain regulatory requirements, then you need to show evidence that you have a health insurance cover. So I believe those are some ways I believe that we just have to think outside the box. The resources are there. You'll be shocked that a woman frying akara can actually make more money than even a cashier in the bank. But how do we get them to commit? And that's the area I believe that if we have this strategic thinking on how to approach either they are banked or banked to get them in the pool and make it very easy for them to be able to make their contributions. And they also must get value for money. That is the only thing that will keep people subscribing to health insurance. If they get to the hospital and they don't get the requisite quality care, then they are not going to renew their premium, their insurance policy. You can get them to buy at once, but if they don't get value, then they are not likely going to renew their policy. Thank you.
Thank you, Dr. Oshuni. I would like you to contribute to that. How do we do this now? Because Dr. Oyinenye has made some suggestions. What other suggestions do you have in terms of ensuring that, of course, especially on the side of quality of service delivery, and from your experience being managing a long-standing HMO, how do we ensure that that value for money is a thing? I do know, for instance, personally, that I've gone to under an HMO cover where the facility told me that they couldn't give me specific drugs because, to them, my HMO cover was not extensive enough. How do we get to that point where, there's a balance of value, really? I've already prepaid. I'm expecting a quality of service, and I get there, and what I'm getting is something different. So how do we ensure that that value is there, and how do we ensure that we mobilize more money for health insurance, for healthcare financing in Nigeria and by extension?
Okay, so there are two questions now. How do we raise money and how do we raise quality of care? The first thing is, a friend of mine once said that the major occupation of a third world country should be to get rich. I told you earlier that our budget in 2022 is about the same as it was in 1979. Yes. The economy is not growing. When we started House Job in the early 1980s, you would see capsules of ampiclox on the tables, syringes, needles, all of it. There was a lot, there was plenty. But with a threefold population rise, these things are just no longer there. So we are flaring gas. Our oil is being filtered away by highway robbers. Greek exports are next to nothing. Little Holland is producing $100 billion worth of agri exports in a year, in a land area the size of about Oyo State.
Oyo State, yeah.
Yeah. So we need to create wealth. Without that wealth, nothing is going to work. Everybody is going to starve. Now, we are talking about paying 15,000 naira per person per annum for a health insurance premium mainly for the low-level social health insurance premium. What is 15,000 naira in dollars? It's about $20 per annum.
$20, yeah.
Average premiums in the United States of America, health insurance premiums, $10,000 a year. So, and you want the same quality of care. You want to use the same medication. You see patients come to say, doctor, how can you give me this generic drug? It's a poor country, and we need to face the fact that it's a poor country. And we need to deploy our every effort to reverse that very, very sorry trend. Okay, so that's one. Of course, the other matter of quality is tied up with it. Between January and now, the Naira has lost 20% or 15% of its value against the international currency, which we use to buy everything we use in medicine. So how do you sustain quality of care in an atmosphere or an environment where the value, the buying power of the currency continues to deteriorate by the day? A friend of mine told me once that he visited Mexico many years ago, and the rate of depreciation of the Mexican currency was so fast that you can enter a bus at one price, and by the time you come off the bus, the price of the ticket has changed. It can be that bad. We also saw the example of Zimbabwe. So we need to halt that trend that is eroding our wealth, and making nonsense of these calculations for 15,000 were made late last year, 2021. At that time, the Naira was 500 to 1. Today, the Naira is approaching, the dollar is approaching 700 Naira to $1. So it's already made nonsense of those calculations.
True.
Yeah. So that's on the macro level. On the macro level, it's a fiscal thing. We just need to generate this money. Somebody once told me that if you export ginger, there's $10 billion worth of ginger exportable every year from Nigeria. Oil has become secondary. How much are we doing with oil? Most of it we are consuming. We consume 400,000 barrels of oil a day. In-house, in-country. The rest that we export, 3/4 of it is stolen, or gets into the wrong hands. So it's a major problem. And then for business to thrive also, there has to be peace. There has to be security. The roads have to be good. You have to be able to move goods from the hinterland on rail to the ports where they can be exported. So every sector of the economy needs to contribute to this drive for advancement. And then it will be easy to get the money to fund the vulnerable and to pay our taxes to grow a country. We lost the opportunity of doing that with the pension funds. Countries like Chile developed a whole lot of infrastructure, roads, bridges, hospitals with their pension funds. And these investments came back. So they were not lost. That opportunity was lost. So private-public partnerships that will be wealth generating are also things we can look into. I don't want to go into the minutiae of one clinic or the other and all that. But the problem for the banks is that the cost of money, if you do what they call a discounted cash flow, you will find that you need to use a factor of about 40 to 50% as a discounting factor on your money. And when you do that with a hospital investment, it's going to end up negative. It just doesn't make economic sense for the banks to invest in hospitals, which are very narrow.
Negative, yeah.
So it's a whole lot of problem. It keeps me awake at night, but what are we going to do? We have to keep up.
Thank you so much, Dr.
And one last thing. Thank you, Nelly, for pointing out the digitalization aspect. We need to have everybody on file so that we can tax everybody. We know who they are, where they are, and they can pay tax. So, yeah, thank you very much.
Thank you so much, Dr. Shuni. I just want to come briefly to Nelly. It is good you spoke about Nelly for a bit, and we're basically on the borderlines of of this episode. And you have a question, from the participant, and it talks to the idea of Nigeria's sugar sweetened beverages taxation, our own taxation that we started. And it was for us, it's the Honorable Minister for Finance, and the government was talking about the strategy of raising money that will be used into healthcare. I do know that Kenya has some of those kind of approaches as well, and in terms of taxation. But the question here is, how do we then ensure that those kind of taxes are appropriately, what kind of practical strategies can we use for ring fencing such kind of those kind of taxation? Because first, there is a concept of, we've talked about remittances, we've talked about collection. Now, how do we ensure that after we've collected, after it has been remitted, then the money now actually gets to the point where it's able to first, like Dr. Oyena talked about and Dr. Oshuni alluded to, create some form of wealth in the process that can now go into healthcare appropriately, and then build up that healthcare system that makes it a higher quality and a higher value for everybody.
Good, thank you for that question, and I completely agree. First of all, with Dr. Leke, we must grow the pie. The fiscal space is limited, and it will continue to shrink. We really must grow the pie. So that means we need to think about our manufacturing industry. We need to revamp our economies. We cannot run away from that. Otherwise, no matter how many declarations, Abuja declarations or Nairobi declaration of 15% or 20%, if the pie still remains this small, we will never be able to fund our healthcare system. So going back to ring fencing, I think I must first of all state that each country context is very different in terms of how you enact your policies and all that. But overall, this is a political economy issue. Health and politics can never be separated. They are twins. And so, the first thing is the political economy must be considered, so that then we understand how do we carry out these health financing reforms in our countries. And so for ring fencing to become possible, there must be political will. There must be understanding by the leaders of the day, both from the executive all the way from to Ministry of Health, technical teams also in Ministries of Finance, that health is critical, number one. Number two, how have we packaged that? Because we in health, doctors and nurses ourselves, we speak to ourselves. We know why we need, a mother to deliver in the hospital, why we need HIV drugs, but we speak to ourselves, and that doesn't augur, or our counterparts in Ministry of Finance who will allocate these resources don't understand. So can we package our asks in terms of return on investment and looking at what is the return on productivity when our people are more healthy? What does that translate to in actual monetary value? When we think about economic returns, when we are taking away that out-of-pocket expenditure from, that Nigerian and that Kenyan, can they channel that money to do business, create wealth? Well, their healthcare is cushioned, right? If we make such a case, then it makes sense, and why someone would make the policy decision to actually ring fence that money. So it ceases from being a political declaration where sugar will be taxed, but translates to a practical policy decision that yes, it will be taxed and ring fenced or set apart only for health. And then the third aspect is the value-based healthcare, as a lot has been mentioned about that in this call. What is that minimum package of care that we are giving our people, that we are sure if we give this to our people, it will be of value, it will be of quality, it will be affordable and sustainable, and hence we will get the health outcomes, that we want. If we then are not able to tick those key boxes, it will be very hard to convince, Ministry of Finance not to take that money to build roads or bridges. Instead, use it in healthcare. But again, I must say that it's a process. Again, and in even universal health coverage is a journey. The most important thing is, are we making steps in the right direction? And I think, to be fair, there are some steps that are being made, but of course, a lot more needs to be done in terms of now translating policy to actual action. Yeah, that's what I would say. Yeah.
Thank you. I want to bring my final questions to Dr. Kulaja before we do final rounds of comments. And this is basically because you sat on both sides of the fence. Now you sat on the international development side with the IFC. You have experience as a health economist, and also you now sit advising government in terms of helping to position health system strengthening. How can we appropriately balance, just like Nelly has said, around ring fencing, the interest of government, our, what you would say at this point, our international development better financing, if you let me say that, and then balance the aspect of healthcare delivery. So if you let me put it appropriately, how do we balance the concept of political will and political action, or how do we translate political will into political action, as, people within the healthcare space to actually elevate the interest of people in government or decision making to ensure that they can either appropriately allocate resources to healthcare or even guard the resources that we already have in healthcare. And then international development organizations, how do we then position them well enough to be able to see that they are also champions of quality healthcare delivery without doing other things that would have actually improved or strengthened the healthcare system across the continent. Dr. Okulaja.
Thank you very much. I'm not sure if you can hear me. The network seems to be breaking. I don't know if it is yours or mine. But as this may be the last time I'm speaking on this call, first of all, I would like to recognize the contributions of all of my senior colleagues on this call, especially Dr. Onya, Dr. Lekio, Dr. Leke. All these are my egbons in this whole business, and I just want to recognize them and say that they've been part of a journey of trying to create a pathway to universal healthcare coverage in Nigeria, and they deserve some accolades for that, especially with all of the information that has been provided on this call so far. A lot has been said, and I've actually sat down and I've listened, and I'm not sure a lot of people will get what is going on. I mean, I was listening to Dr. Leke, and you would see that he had moved very, I wouldn't say far, but he had moved away from the conversation to then talk about a holistic approach to health financing. And this is what is necessary. We need to begin to look at how we can bring together all the relevant pillars to be able to achieve our goals. Now, one of the things I've realized, and as you stay longer in your roles, you begin, epiphanies occur to you. I realized that over the last couple of years, Nigeria has been building healthcare systems for the poor, rather than building sustainable healthcare systems and then facilitating the access of the poor. And if we continue to build healthcare systems for the poor, then it will never be sustainable. Because what we'll continue to look for is to look for funding to pay for that healthcare system, as against looking for a way that we can all contribute to a pot, both the rich and the poor, to be able to, facilitate a sustainable healthcare system.
Dr. Onya, just give you a round of applause for that statement.
if you look at what Wale has also said, I'm someone that I'm not ashamed to say I've been wrong or I've been right, but for a very long time, I've always advocated for concessionary funding. But the reason why I've been advocating for concessionary funding is because even at that time also, I've been looking at building healthcare systems for poor people. I trained a board of a health insurance agency recently, and I asked them during the training, I said, how many people on this board have your health insurance card? Only one person raised their hand. And then, I said, the reason why it's only one person, because you yourself, you do not value the health insurance scheme that you are selling.
That you're offering. Wow.
If you valued it, it will not just be a card that you have put into your wallet as a demonstration of you also being part of it. It will be something that you actually see some, value that it can provide in terms of offering health insurance or health services. And until we begin to think like that, until we begin to take ourselves seriously, the government will not take us seriously. And that's just the truth, right? I studied the budgets of the Federal Republic of Nigeria and 4 states. And I saw one line item that was constant. It did not have any babies. Normally you would have, Ministry of Health. Under it, you have Primary Health Development Agency. You have, this was just one line. And it accounted for between 11 to 57% of entire budgets with 100% performance. You know what that line item is? You know what it is? Economic affairs. That line item is just called
Economic
affairs. That is it. So what that told me is that government will allocate, spend, and invest money in anything that they see some level of economic gains from. If they do not see any economic gain in it, then it will not work. And so we need to begin to see how we can make healthcare a resource contributor as against a resource consumer for government to begin to take us seriously. And for us to do that, we need to be sustainable. We need to be able to stand on our own and be able to generate enough resources to ensure that we can be able to provide the required access in an egalitarian system. I'm someone that believes in the rule of ones. I don't believe in multiple benefit packages, multiple insurance schemes, multiple rule of one. Let all of us have one basic package that we are all contributing to, that we can all access. If you are now rich or you now feel that you need additional ones, go to the private sector or wait for us to increase the benefit package, right? But until we are able to come together and develop a sustainable health financing, and that's another mistake we make. We always juxtapose health insurance for health financing. It's not the same thing. I think it was Dr. Onya that was speaking, or it was Dr. Oshunui that mentioned the different types of health financing mechanisms that can contribute to a pool, right? And so we cannot leverage on just one. Health insurance is not the panacea for raising funding for health financing. So we need to begin to think about that. And we need to begin to also see how we as the health sector can join hands with government to improve, widen, and deepen the tax bracket. Very, very important. So these are some of the issues. I mean, the conversation that you have brought on board is not something that can be discussed in a particular. Absolutely. There are far and wide reaching depths to health financing and the issues that plague us in Nigeria and in Africa. But I think that if we're able to address some of these things, then we might have some form of traction. Thank you very much.
Thank you. Thank you so much, Dr. Okulaja. That was very, very, very beautifully put. Conversations with very, very, very experienced panelists. Speaking on how we can, as Africa, of course, with reference to Nigeria and Kenya, build a sustainable healthcare financing framework. We dwelt a lot around health insurance. We signed to law and launched National Health Insurance Authority in Nigeria. We spoken about tax, Nigeria's sugar tax. We talked about ring fencing, and we just spoken about how do we move from political will to political action. And one of the key things that Dr. Okulaja and everybody has spoken about is we need to make healthcare attractive enough. Adebowale rightly mentioned that healthcare providers sometimes don't even have the required documentation. They are not, if you let me use, for lack of a better word, they are not well packaged. They are not attractive enough for financing options that already exist to actually get into them. And we do know that this conversation, this episode cannot fully exhaust all of the conversation around the healthcare financing in Africa, but we see this as a contribution to that conversation of getting people aware around their need to ensure that we create processes, framework, approaches, methodologies, strategies that actually help us mobilize sustainable financing into the healthcare minimum by a factor of 30%. I was looking at a research from India where, women's health, women that were working in coffee farms, that their health for their site was just managed and their product health. So you can imagine what it would be if their entire family is covered by health insurance, and they know that, that is not a worry that they need to have. So it tells you how health is a critical driver for economic productivity. Health itself can be a contributor to national development, as we've rightly said on this episode. And, one of the things that we're excited about is that as an organization at GREED, we're committed to building and bringing, value into the healthcare space through what we do with technology and solutions provided across, different sectors, including healthcare. So we're excited that, we've been able to host this wonderful panelists. We say thank you. We thank our participants from different parts. We say hello to you and we say thank you. And we'll share with you the videos, the commentaries, the behind the scenes as well, from this episode. And we look forward to having you some other time. Interestingly, what we want to be able to do is to engage and bring thought leaders into this space to speak about critical issues, like I said, to accelerating our attainment as a continent of universal healthcare coverage. We have resources to do. We just need to be with us. Thank you, Dr. Kini. Thank you, Dr. Onya, for sparing your precious time. You can just put on your camera for now so we can have just a simple picture as we go. Thank you, Dr. Oyeneyi, this has been wonderful. Nelly, thank you so much for being here. Adebawale, again, Dr. Kulaja, thank you so much. This is something that was just something we said that this would create value for us, not just as an organization, but bringing the right mindset. And one of the things we've seen on this call is if we have the right mindset as Africa, we can then achieve a lot of success. If we have the right mindset as a continent and as a people, we can achieve a lot of growth. Thank you so much for coming. Thank you so much for sparing your time. And, on behalf of the GREED team, on behalf of everybody on this side, we say do have a wonderful evening. It's been an excellent 2 hours of intensive, mind, opening, insightful, exciting conversation. I'm looking forward to when, I'll probably be sitting on the other side with people and sharing some of your wealth of experience as if they were mine. So I'll be standing on the shoulders of giants, speaking out about how health insurance is supposed to be done, how sustainable healthcare financing will be done. Please look out for our emails, everyone, and goodbye for now. Thank you so much.
Thank you. Goodbye.
Thank you. Goodbye.
Bye.
not like you have quality healthcare, you now have, sub-quality healthcare that we can manage. Can health be anything but of quality?
There has to be a wider approach to address fundamentally how healthcare needs to be improved in quality, in delivery, in accessibility to the populace.
Well, we should build sustainability and systems into what we're doing in healthcare. And the private sector comes with an incentive to build that.
So I traveled to pretty much every country in West Africa. And what I realized was, this is not a Nigerian problem. This is indeed an African problem.
Francophone from Anglophone. What are the similarities and what are the differences? Let's marry and find what works per country.
Every country has its own peculiar realities. And I think we need to explore what these individual realities are and tailor-make the solution.
To look inwardly, we need to assess what the situation is. We need to customize our solutions and we need to apply them.
We need to find our own model that works. If accessing care right now is just for the rich, what can we do to accelerate its access to the middle income and ultimately to the bottom of the pyramid? How can we dismantle models that have served us for decades but are no longer the ones that are relevant?
Bringing in deep business models that have worked elsewhere.
What models can we begin to use now to get Africa to a more comfortable space?
Really seriously thinking about capitalizing the health sector is fundamental for Africa's health.
Universal health coverage is a spectrum of care. So the question is, when you look at this spectrum, how well, are we able to deliver the care that our people need?
For the diagnostic space to thrive and for efficient testing to be done in scale, it's really important for the marriage of private and public sector to happen.